We're actually going to start on time because we're on a pretty tight schedule. Marty Goldman, welcome to the first visiting professorship program of the year. We're very excited. We had a tremendous lineup of fellows as our visiting professors. And we also have 14 fellows who are here for interviewing for our program today. So we're very excited about having them. Welcome to them. Today's program is actually one of the most important that a cardiologist can attend. It's a preoperative evaluation of the cardiac patient. We have a very special visiting professor today who's well known to all, Glenn Levine. Dr. Fuster will introduce him in more detail. I'll just tell you a little bit about the phenomenal lineup of people we have coming for the rest of the year. Bruce Lerman is coming in October, Steve Marks from Columbia in November, James Januzzi from the Mass General in December, Scott Gottlieb, a former medical resident here at Sinai, who's head of the FDA, will be here in January, Harlan Krumholtz from Yale in February, Martin Marin from Tufts in March, Glenn Fishman, NYU in April, Callum McCrae from Brigham and Women's in May, and in June, last but certainly not least, Robert Califf from Duke. We have a very busy program this morning, so without further ado, Catherine Michaelis has put together a monograph which is available outside, and she's going to summarize a really wonderful paper in just a few minutes.
Good morning, everyone. Thank you so much to Dr. Fuster and Dr. Goldman for the opportunity to take part in this conference. Dr. Levine, I'd like to welcome you again, and thank you for joining us today to share your expertise. It's truly an honor to be in conversation with the distinguished members of this panel. Now I would like to introduce the topic of our panel discussion, preoperative evaluation of the cardiac patient. Cardiac patients are particularly vulnerable to adverse events in the perioperative period. The postoperative state is characterized by release of catecholamines and cortisol, inflammation, and thrombosis, a perfect storm for cardiovascular injury. Increased wall stress as a result of tachycardia and hypertension can lead to plaque rupture or thrombosis, while demand ischemia can result from tachycardia, hypotension, anemia, or hypoxia. Within the United States, the incidence of perioperative major adverse cardiovascular and cerebrovascular events is estimated to occur in 1 out of 33 hospitalizations for non-cardiac surgery, most frequently in patients undergoing vascular, thoracic, and transplant surgery. Among patients with cardiovascular disease, patients with CAD or heart failure are at the highest risk for perioperative complications. Additionally, special consideration must be given to patients with valvular disease, especially in this era of evolving percutaneous structural interventions. Estimation of perioperative cardiovascular risk involves evaluation of each patient's clinical characteristics and procedural risk, assessment of functional capacity, and non-invasive stress testing. Patients with a low or less than 1% risk of MACE, according to a validated risk calculator, such as the Revised Cardiac Risk Index, do not require further testing. Non-invasive stress testing is recommended only for patients at elevated risk for MACE and with poor or undeterminable functional capacity and should not be routine. Most studies suggest that a normal stress test has a very high negative predictive value. Results of the CARP trial form the basis of the guideline recommendation against routine revascularization for patients with stable CAD. In this trial of patients undergoing elective major vascular surgery, revascularization with PCI or CABG had no effect on long-term mortality or 30-day postoperative rates of MI. However, the exclusion of patients with significant left main stenosis, as well as the low percentage of patients with triple vessel disease, raised the possibility of a selection bias for patients least likely to benefit from revascularization. In fact, reanalysis of the CARP data showed that patients with unprotected left main disease derived a statistically significant long-term survival benefit from revascularization. Currently, the 2014 ACC-AHA perioperative guideline recommends that revascularization be performed prior to non-cardiac surgery only if otherwise indicated. Recently, a series of trials have established that shorter durations of dual antiplatelet therapy are appropriate for patients with newer generation drug-eluting stents because of lower rates of stent thrombosis. As a result, the 2016 ACC/AHA updated DAPT guideline recommends that elective non-cardiac surgery in patients treated with drug-eluting stents should optimally be delayed at least 6 months, but can be considered after at least 3 months based on risk-benefit analysis. Patient age, type of stent used, stent length and size, and number of stents placed affect the risk of stent thrombosis and should be considered when deciding DAPT duration. For patients who need to undergo surgery sooner, the recommended strategy is to use a bare metal stent and discontinue DAPT after 30 days. Mount Sinai's own Roxana Miran and Usman Babar were two of the lead investigators of the Paris study, which examined the effect of DAPT sensation on risk of MACE. One of their major findings was that brief interruption of DAPT due to surgical necessity does not significantly increase the rate of thrombotic events. The literature about beta blocker therapy in the perioperative period has been especially controversial. The decreased family of trials were largely discredited due to concerns for scientific misconduct. Additionally, the POISE trial showed that perioperative beta blocker therapy was associated with an increase in all-cause mortality and strokes, although these results reflect the effect of starting a high dose of extended-release metoprolol just hours before surgery. Other studies have demonstrated the benefit of perioperative beta blockade in intermediate to high-risk patients when started at least 1 day before surgery. Perioperative statin therapy is generally associated with lower all-cause mortality. In summary, cardiac patients require thoughtful management in the perioperative setting due to the potential for adverse outcomes. Despite some conflicting findings in the perioperative literature, one unifying theme is that a personalized, team-based approach to each patient leads to the best outcomes. Thank you.
Well, thank you very much for an excellent presentation and monograph on a very difficult and complex subject, as you will see in a few minutes. But I'd like to, it is an honor to introduce Dr. Glenn Levine to, maybe it's the first time you visit Mount Sinai? Yeah, it was very nice you came and early in the morning with the change of schedules. Anyway, Dr. Levine is a professor of medicine at Baylor and director of the cardiac care unit at the Michael DeBakey Medical Center, and is the chair of the present ACC/AHA guidelines, clinical practice guidelines. So he's a New Yorker, so this is a good start of the morning for you. He was born in New York, and actually he had his undergraduate education at Cornell. And then he obtained the MD degree at Columbia University and the College of Physicians and Surgeons. And then he went into Boston. Not so good, but fair. He had his internship, residency, and fellowship, and then interventional fellowship at Boston University. Then moved into Houston, where he became the director of the cardiac cath lab, chief of cardiac critical care, then director of the cardiac care unit. You have been director of everything there. And then basically he also in the imaging, director of the cardiac CT, and presently, as I mentioned, professor of medicine and chair of the guidelines of the American Heart American College and director of the cardiac care unit. Now, in terms of his accomplishments are numerous. I would say that in his own institution in Houston, he's actually is director or co-chair or chair of 10 different committees that have to do with research, academic endeavors, and actually educational. Then I will add that with American Heart, he's also, he plays a prominent role in 10 other committees, And then I will say that it is very important what he's doing for the guidelines. He has been involved in one way or another, not only in guidelines, but in a number of projects, at least 20 different projects and different cardiovascular entities. And certainly he's playing a key role, as I mentioned, at the present time in the guidelines. So I'd like to move on and tell you something else. He's not only involved with all these enterprises locally and nationally and American Heart, American College, but he has a very interesting accomplishments of social responsibility as a member of the Green Pace International. And then he became involved with these smiling dogs. What is that? Can you tell us about the smiling dogs? You will tell us later. Yeah, dogs smile, and he's going to convince you about it, but he's really very involved with committees on dogs in this country, rescue dogs and beginning golden retrieval rescue and so forth. So he's very, very involved from this point of view. We all love dogs, so you have, I have to say, congratulations for doing that. Now, academically, he's an accomplished person. First of all, in 2015, he received the Distinguished Achievement Award of the Clinical Cardiology Council of the American Heart Association. As I mentioned, he really is involved. He has been involved in one way or another in 20 trials. And most importantly, he has a very rich literature in all the aspects of cardiovascular disease. He's one of the people that you can invite to any meeting to talk about anything. And he has about more than 75 papers. And it's interesting what the papers are certainly about all the different topics. But I will say to you, the first one had a significant impact, and I still remember reading it. It was in 1995. Cholesterol reduction in cardiovascular disease, clinical benefits and possible mechanisms. This was in the New England Journal of Medicine. And it was one of the key papers that you do not forget. But just to tell you a scope of the individual, his last paper is now coming out, is still in press, Meditation and Cardiovascular Risk Reduction. So I'm just giving you the scope of the individual who is visiting us today. Well, thank you very much for coming to New York, visiting your own town, and for giving us the time to really touch into a subject which is quite controversial and quite interesting. Congratulations. I have to give you this. Here is our plaque that reads the faculty and fellows, and all of you deserving this outstanding teaching, wisdom, and expertise as the Anandi Sharma Visiting Professor and the Simon Duck Memorial Lecture. You remember Simon? Simon Duck?
Yes.
He was here. He was actually one of our staff people here. Martin, I don't see the check. Oh, you have it. All right. Just it's not big, but you know. Anyway, let's get a picture. Sharma, come here because it's devoted to your father. Nandi Sharma was the father of.
Hey, great to see you.
Just put it in the middle.
Yeah, you're in the center. Yes.
Just go a little bit more that way.
Okay.
Okay, good.
Good. Thank you so much, Dr. Fuster.
So thank you very much. Glenn, you can sit there in the middle. And we are now going to call all the experts here. Roxana? Yeah. Tara is here? I don't see Tara. Oh, she's coming, yeah. And then Prashant, of course. Steve. And then obviously Catherine. Is anybody else? Jonathan, do you want to be part of this? Yeah, okay. And good.
Amber alert.
Well, this subject is a paradox. In a way, you can say, I look at my intuition and I decide what to do with my patient. If the patient is going to have elective surgery and has cardiac disease, I will decide what to do, what to tell the anesthesiologist with all the data available in the literature. It's huge. And you can follow your own gut feeling. The only problem is you send the patient in and the anesthesiologist calls you saying it's not acceptable because you didn't do this, this, and that. This is what you should read to know what you are talking about. And I want to ask a question here, just to start. These are the guidelines of the American Heart Association, American College, the last ones, and European guidelines on how to address patients who are with cardiac disease that are going to have non-cardiac surgery. Can you raise your hands, those who read this document? Yeah, they read it yesterday. And here comes the issue, with the guidelines that you are now chairing, and John Halpin chaired this before, it's pretty tough because you spend hours and hours and hours on a line, on a comma, on this word, this other word. And at the very end, the question is, who reads these guidelines? And I think we go there when we need a case, we want to see something specific, but very rarely people can really absorb this. Very, very difficult. I try it, and I will tell you, you will tell me at the end if I learned what you need to know or not. But let me go on. Complicated.
Well, you should let him comment because I think there's some changes coming.
No, I will do. We'll ask you. He has many things to talk about us today. But let me tell you how I'm going to divide this. I'm going to describe first the history of this type of patients, the cardiac patients with non-cardiac surgery. And the history is very troublesome. Constant changes. Even the guidelines of 2016 are completely changed the data in 2017 with the data that came out this year. Complete change. So just to give you a sense of the topic we are discussing. So we'll go into the history first. And then we'll go into the bottom line, and that is there are 4 parameters here. What is the disease that the patient has and how severe it is? The next question is, now you face surgery. What is the timing and what is the risk of the operation in itself? And then, depending, you have to go into the functional class of the patient, and at the very end, you decide if you do non-invasive testing. This is quite interesting because, as you will see in a moment, people go into non-invasive testing to start with, and then they begin to address all the other issues, which is not right. Then we'll talk about the approaches that you have once you have decided when, how, and the risk. And that is, do you use beta blockers? Do you use statins? What do you do with the antiplatelets and the anticoagulants? That's another subject. And finally, we are going to talk about stenting and dual antiplatelet therapy, although this probably will be the discussion that we will have this morning at noon. Dr. Levine is going to talk about. So let me start, Glenn, with the history of all of this, which is somewhat interesting. I still remember Dr. Boucher at the Mass General. He was the one who wrote a paper who really shook up the whole world. He had a study in 1985 in which, by using dipyridamole thallium imaging on any patient going to surgery, he found a huge mortality on those who have positive tests. And this really was a driving to the whole community to use non-invasive testing to any patient undergoing any kind of operation, because you may feel right, but you may have coronary disease. Who knows about it? Let's now use a thallium study. Well, that paper really moved into many people with new labs and so forth, and was most of the patients going into these labs were preoperatively. Then what happened is that with time, things began to be more directed to patients who were at risk. And those who were not at risk at all, you are not going to do a treadmill testing on a 30-year-old, who is going to have elective surgery. or with no risk factors and so forth. So it began to discriminate. Then something good happened. The new way to address risk. The first one was the revised cardiac risk index. This was the first one that, and they look at a number of parameters, and that is what you should do for patients undergoing elective surgery and have cardiac disease. What is the risk? And this involved the risk of the procedure, and then whether the patient had coronary disease, congestive failure, cerebrovascular disease, a high serum creatinine of more than 2, and the patient having diabetes. So that was the first addressing the risk of patients undergoing non-cardiac surgery who had cardiac disease. And then in the last 15 years, a lot of changes have been made, but what I'd like to discuss in a moment is what happened with two topics in particular, which is revascularization and perioperative beta blockade. Before I go into that, I'd like to ask you, Glenn, this field is changing constantly. What is going on? There are no trials, and therefore we have to get a study from here and there in time to pull them together. What is really happening?
I think it's hard to do a definitive trial other than a negative definitive trial. And I think that's been one of the challenges, particularly in translating the trials to guidelines. I also wanted to make one comment that was prompted by your mentioning of the 1985 thallium test. It's interesting, if you read the American and European guidelines, one thing they're very careful to highlight is that the predictive value of a positive nuclear stress test has actually gone down over the last several decades, and that's believed to be due to better surgical and anesthesia techniques. But that to me is a huge difference in that a positive stress test in 1985 is a lot different than someone who just has a quote positive stress test in 2017 on whether we still send the patient to surgery or not.
Yeah, Roxana, you have any comment about my question? Is that having so many fluctuations on this?
No, I think regarding this particular issue is that, in 1985 also, I think the background medical therapy was so minimized. We now have statins and lots of other things to do on the medical management of the patients, and we're doing a much better job. But this fluctuation, I think a lot of it has to do with how difficult it is for clinical trials to keep up with clinical practice, because clinical practice is changing so much, Dr. Fuster. And I think that's a really huge challenge. And having been honored to be part of the guidelines, I really recognize the kind of work and effort that goes into this to try to be as minimally biased, but yet keeping up with the clinical practice. But everything has to have at least some clinical evidence, and it's hard to do that.
Yes, but Prashant, I'm sorry to tell you, and you have been a real pioneer in this field. He has a number of papers with Kim Eagle on this. I still see again and again and again consultations do a stress test on people who undergo surgery. This is the reality, when in fact the data is close to zero, as we will discuss in a moment. So people are very difficult to change. What is your opinion of that?
You mean the temptation to do a stress test?
And then what do you do with that test?
So I think the challenge is to continue to separate to view the patient separate from the perioperative encounter. So and I think that is the challenge. We see these patients and we see them having a surgery, and we see them with the temptation to clear them for a surgery, but we need to change that culture, and we see the data. We see the data. If you look at patients who are having, say, cataract surgery, and if you look at the data from like 1998 to 2006, even for a low-risk procedure like that, 20% of those patients will have a preoperative consultation for such a low-risk surgery. So there's a culture where there's a need to clear the patient, but we really need to modify that, where we think about patients independent of the surgery that they're having.
Well, let me tell you what happened in 1993. I was at the Mass General, and a patient died at the time of a cholecystectomy. And interestingly, the question is, where was the blood clot? It died of a myocardial infarction. And the blood clot actually was not in a ruptured plaque. It was in a plaque that was about 30–40% stenotic. I met with Kim Eagle, and this is the story. And I said, we really should look at this because I don't believe for a moment that surgery makes plaque rupture. So if you have an infarct, it has to be a different mechanism. And at that time, what we thought was there was a catecholamine release during the surgery may make the blood hypercoagulable, and a little bit of an erosion of a small plaque may lead to a clot. This led to a critical paper. I actually took my name out because I only had the idea, and Kim Eagle published this paper. There were 17 cases that he recorded in this country of people who died during surgery and had some coronary artery disease. In most of the patients, I think it were 17 patients, I have to go back. In fact, the clot didn't take place in the area that everybody would expect, very severe stenotic lesion and so forth. So here, what this paper brought into the question is, whatever you want to do with an exercise test, not necessarily the lesion that causes ischemia is the problem. And actually, this is one of the issues. This led to a number of studies, and frankly, I can just summarize today, prophylactic coronary revascularization on a positive exercise test, you just cannot follow that rule because you will fail. You cannot predict, and we will go into this in a moment. But it's just to give you a little bit of a history. But now I'd like to go on the revascularization. I want to go into the beta blockers. Catherine, you described this very well, but this is a nightmare. The beta blockers started with an intuition, and the intuition was that when you go to surgery, you are under stress, and with all the data that was being accumulated, when you are under stress, you are hypercoagulable, and therefore you have to give beta blockers to cool you down. That's the whole issue of beta blockers, how it started in the early 1990s. And then I guess was Dr. Mangano who did a study that was reasonably positive for beta blockers, although not quite convincing. And then, Catherine, as you mentioned, something happened. The Danish group began to publish papers on a trial called Decrease, and the results were out of control. It's like if you have cardiac disease and you go to surgery, you would have a mortality that was close to 20% in some cases. And if you do something to the patient, like giving beta blockers, it's 3%. This passed through, and everybody believed that. And then there is a subsequent study that was the POISE study, in which was positive under huge dosages of metoprolol, but was positive with less myocardial infarction with the use of beta blockers, but more hypotension and bradycardia and cerebrovascular events. So somebody decided to go back to the original data of the Dutch study and was all flawed, was all invented. And this was probably the most catastrophic thing in the literature in the cardiovascular field ever. Was actually related to the topic that we are discussing today. It was all invented. So the figures, and was published one paper after the other from the Danish group. So I just like to ask you, Catherine, what was your reaction to all of this? And then we'll say what the guidelines say about beta blockers.
So I think with beta blockers, obviously it's challenging because of all of the data that has been miscredited. But I think as for kind of other areas of perioperative testing, as Prashant was saying, it's important to look at the patient as a whole, obviously anticipating that they're going to undergo a stressful event, but trying to optimize them generally based on their cardiovascular risk. And so if a patient has other indications to be on a beta blocker, then they should be on a beta blocker, but it shouldn't be started at a very high dose on the same day of surgery. So they should be, it should be kind of started earlier on if that's a reasonable therapeutic option for them, with some time to evaluate how the patient responds, to avoid the side effects that we all know, like bradycardia and hypotension.
So what is interesting, though, as you will see in the guidelines, we'll discuss this in a moment, still people start beta blockers out of the blue, thinking that it's going to look good for the patient. It's absolutely bad, unless the patient has been on beta blockers before and you don't stop them. But we will discuss this in a moment. These are historical points to tell you how complex this field is that has been fluctuating a lot. And I think now we are at the stage that I had two possibilities on this presentation today. One is to present one patient after the other. Very easy. What is complicated is if you don't go into concepts that are really important concepts, we waste our time. We could be discussing here patient after patient. So I decided to really touch into critical concepts of these patients with cardiac disease that undergo non-cardiac surgery, because then it's easy to understand any patient that presents to us. In order to do this, what I decided to do is to touch into step by step. First, the patient. What disease, what cardiac disease is there? How bad it is? The second is you're confronting non-cardiac surgery. And the question is, what is the risk of the operation and what is the timing of the operation? Then you go into a number of cases. In fact, you cannot make a decision at all until you know the functional capacity of the patient. And this is by history, whether the patient is excellent functional capacity, good, moderate, and so forth. And then at the very end, you are left with a very small group that you might do an exercise testing. This is how really the driving force is today. Then there are details that are changing in the last year, but we will discuss them. So let me begin by the patient in itself. And I think it will be important to address the diseases that are most troublesome. And I will begin with Dr. Liao. Maybe you can comment on. One is coronary artery disease. Well, chronic coronary artery disease, actually, it doesn't give much trouble in the perioperative period. I just can tell you all the data is pretty questionable. You should do anything, even with a positive exercise test. But what is troublesome is the acute coronary syndrome. And it's interesting because the most recent guidelines, I believe, Glenn, says if you have an acute coronary syndrome, don't do any kind of surgery, at least for a couple of months. Is this correct? So what is your opinion on that?
Well, I think I just wanted to comment a little bit about what you were talking about before, about testing and why we do the testing so much, even though the guidelines don't really suggest that the testing is beneficial, as you said. And I think a lot of it has to do with the anxiety of the practitioners, the surgeons, and the anesthesiologists. And so I think even though cardiology generally obviously know the guidelines quite well, I think helping to educate these other people in terms of what is evidence-based and not would be helpful. Because in the various stress labs and the imaging modalities that I'm involved with, we do see a lot of preoperative testing, much more than you would anticipate. In regard to stable coronary disease, I agree with you. There's no strong data to suggest that testing is helpful for this. We have other data aside from pre-op data to suggest that this is also true. We have screening data from the DIAD trial for diabetics with myocardial perfusion imaging. And then we have the Factor 64 trial for cardiac CT, also for diabetics at high risk for coronary disease. And neither of these trials show any benefit from imaging studies to try to predict who is going to have a mortality benefit.
Thank you, Tara. I have a patient with an acute coronary syndrome, and he's developing a perforation of the stomach. Next day, 2 days later, I will tell you what is the answer, and then I will ask you, okay, because we are not debating here, trying to, and the answer is you forget about the acute syndrome and you operate, and there is urgent operations. This is very important. It's critical. The timing of operation is when it is within 6 hours, you should do it. You don't care about the heart. You just do whatever has to be done. Then it's between 6 weeks, which is what is a timing issue, some urgency, and then there is elective, which is 6 months. I just want to put this because this is critical. So I'm just would you have the guts to send a patient with an acute myocardial infarction with a perforation of the stomach to the surgeon?
Yes, I think you don't really have a choice because they're probably going to die of that perforation.
Excellent, you have guts, and that's what should be done. No,
But obviously, we would be there with the patient.
I understand it, but
afterwards.
it is very important to pay attention to the emergency of the operation that we say elective. This is not elective, this is an urgent operation, and so forth. Well, then we go into heart failure. Glenn, I read the data on heart failure on recent literature, and I'm a little bit concerned whether the data is correct or not. If you send a patient with a low ejection fraction that is non-ischemic, the chances of having a problem perioperatively, regardless of the timing, is 9%. If the patient has ischemic the heart failure, it's about 10%. And if the patient has atrial fibrillation with heart failure, it's about 8%. Are these figures real? These are the figures more recent.
I first would clarify that in the guidelines and the literature, it's particularly EF less than 29 or 30%, which is really the trigger. But I think in a lot of these studies, there's different endpoints, there's different ways to collect the data. So I think if you want to look at the data and say it's real, it's real. If you want to look at the data and say it's probably not real and not accurate, then I think you can do that as well. And that's one of the dilemmas of much of the literature and data that I think you're pointing out.
Yeah, because, well, anyway, it's just to point out that it depends how severe the heart disease is, but it may be troublesome. Now, Roxana, about valvular heart disease, you know, severe AS, severe MR, severe aortic incompetence. You know, the type of data that I was able to collect goes from 3 to 9% on the severe cases too. I guess it's the similar situation.
I think it's similar, but I think nowadays the approach to valvular heart disease has really changed dramatically. There's a team approach in really kind of thinking about what's the best medical management and, you know, surgical or transcatheter management. And I think these patients who have concomitant coronary disease with aortic stenosis, they're going to be at a higher risk. And I think that there's a lot of team approach talking about how to manage them perioperatively, whether or not they need to have, depending on the type of procedure. It's very similar to everything else that you've said. But I think the approach is a lot better and improved now that we have a team approach.
The critical issue is hemodynamic monitoring. That's the critical issue in all these types of patients. What I am surprised is the data on arrhythmias actually is not bad. I mean, you can have any kind of rhythm disturbance except if you are in atrial fibrillation and heart failure, or you are on ventricular tachycardia, but all the other rhythm abnormalities do not cause any much trouble. Actually, you wrote about this, Prashant, and I'm reading what you said. It's not a real problem, the issue of arrhythmias, in terms of the time they are being managed properly. Is this correct? You wrote it?
I did, yeah.
It's correct, all right. He's consistent.
I want to talk about the smiling dogs.
Well, and then we have pulmonary vascular disease. We all know this is a real issue, and I don't think we have to discuss it any further. What I would like to discuss now, we have the patient with cardiac disease. Almost all patients are operable, but obviously the risk increases. Now, let's go now into the operation in itself and the timing. And I just want to emphasize, because this is critical in the whole outline of the algorithm. So an operation, you have to decide how important it is, and there is the so-called urgent, within 6 hours. There is so-called time sensitive, which is 6 weeks, and then the so-called elective is 6 months. So I think this is very important issue to keep into mind when you are really having a patient in front of you. Now, what is important here is if the operation is not urgent and you are time sensitive or elective, then what is the next step that you have to think about it? Well, the next step you have to think about it is what is the risk of this patient according to the risk formulas that are available, which are 3. And I have to go very carefully on this because it's actually an aspect that is very important. And that is, how do you assess the risk of the patient on a timing of surgery that not necessarily is a surgery that has to be done urgently. And you know, the first one I already mentioned is the so-called the revised cardiac risk index, the RCRI, which is used quite frequently. The other one is by the surgeons, the National Surgical Quality Improvement Program, which one kind only looks at myocardial infarction and cardiac arrest, nothing else. And then there is the so-called, the same one, NSQIP, surgical risk. It looks at all the other aspects, looking at 21 different parameters. What is interesting is, regardless of the kind of risk that you look at and all the parameters, the results are not too distant from one type of modality that you use versus the other, but there's something very important, and that is, once you do this, whether you're dealing with a risk high of mortality of more than 1% or less than 1%, that's the critical issue everybody is aware of. I'd like to ask Glenn if this is so important, because here's where you begin to derive whether if it is less than 1% the risk, you send the patient to surgery based on that risk classification. If it is more than 1%, is actually, then you have to do other things. I want to ask you, and then I want to ask Prashant, because Prashant was part with Dr. Eagle of this particular risk approach.
So as with much of our guidelines, I would consider our guideline just a guideline, not a mandate. They're generalizations. So this 1% number, that is something that is convenient to come up with in a recommendation. So if you're asking me would I treat the patient whose risk is 0.9% different than the person whose risk is 1.1%, then my answer is no. I would use that as one piece of data, but certainly not as the single driving piece of data in making my clinical decision.
This is another paradox, that we have to individualize our patients, but you have to have a team effort in order to come to a judgment. But I think it's critically important, and I didn't realize this personally, how important is this risk factor profile in the algorithm that you follow and what do you do. And when I say it's less than 1%, by these three formulas, means you move off into surgery, and more than 1%, you really move into the next step. But I think you have to individualize. Prashant, any comment about this risk approach with the three formulas?
I think a few comments. I would say, you know, so I agree with Dr. Levine in terms of individualization, you know, starting one with functional class and capacity for physical activity. You know, I think kind of independent of a score on the RCRI or the surgical calculators, you know, if a patient has a very good functional capacity and is able to produce, you know, at least 4 METs or exceeding 4 METs, you know, that speaks well to being able to do well in a surgery, number one. Number two, the risk scores are guideposts. So even if a patient has a high RCRI, so if an RCRI is greater than 2, that again has to be factored into the context. If it would change, if that score then would change what would happen independent of what is happening in the perioperative encounter, then it should factor into decision making.
Well, it's nice you mentioned this, because I will tell you how the algorithm grows. First, you go into the mortality, and then you go into functional capacity. In other words, if the mortality is low, functional capacity is not assessed. I'm just talking in a very strict manner. If the mortality or the risk is more than 1% or whatever you individualize, then you look at functional capacity, which is critical. Now I'm beginning to understand it's critical in all of our patients, and I want to define it because it's something that we really have to keep in mind. And this is an excellent functional capacity which will send the patient to surgery, even at a high risk of more than 1% or more than 10 METs. This is the runner and you know, the guys who do all crazy things physically without any problem. This is excellent. The second is good, which is 7 to 10 meds, jogging, skiing, again, the patient may be at high risk, but you send the patient to surgery. The mortality is low. If it is moderate, 4 to 7 meds, bicycling, tennis, and so forth, again, it's possible to send the patient to surgery if the risk is reasonably more than 1%, just to put a number. The problem is when the functional capacity is poor, less than 4 meds, that is, the patient has some kind of disability, walking or even playing golf and so forth. And actually, this is the patient that you do non-invasive testing. This is a very huge issue. So we are moving from non-invasive testing at the beginning of the whole enterprise into a number of people who are left, and the whole assessment is very clinical. And this is something I want to emphasize here. And I think, Glenn, you are in agreement with me. When I said at the beginning, there's an intuitive feeling in all of this that really plays a role. What we are trying to do is to follow rules and going one step into the other.
I couldn't agree more, and as an aside, I couldn't appreciate this lead-in to talking about the frailty of risk scores, individualization of care, and using common sense, a perfect lead-in for what we're going to talk about during my noon lecture. So I am very appreciative of the way you are leading into my talk, and we are completely on the same page.
Well, thank you. I think the whole issue that I just wanted to just summarize we have done thus far is to see the patient, may have cardiac disease, it depends how severe it is, you have to be more and more careful, but there is no such a thing as saying there is no way the patient should be having elective surgery. On occasions, we face the case that we operate first the patient from the cardiac point of view if what is elective is not so important. This is, again, is a lot of common sense. But the importance of the timing of surgery, and that is if it is urgent, you move on into the surgery. And if it is less urgent, then you go into the risk stratification. And if the risk stratification is reasonably is good, you go for surgery. If the risk stratification goes, the risk is a little bit high by the 3 formulas, is then when comes the functional capacity. And if the functional capacity is good, you go to surgery. If it is poor, then you do the testing. That's as an algorithm. Now let's go into specific approaches. And the first one I would like to touch is into the beta blocker deal. We discussed this a few minutes ago, in which this is a little bit of a controversy, but I will tell you what the guidelines show, and Glenn, you correct me, because I think the European are very similar to the American guidelines, and that is you should not start on beta blockers somebody undergoing elective cardiac surgery unless the non-invasive testing that we mentioned before is very positive and so forth. So there are exceptions, but this is basically the issue. Second, if a patient is on beta blocker, excuse me, and if you start, which will be more an exception than a rule, you should start 2-3 weeks before very slowly because there are lots of problems with rebound. The second, if a patient is on beta blockers, you continue, and then but otherwise you don't use them. Is any comments, Catherine, about this, just to be sure that we understand the beta blocker field?
Yeah, I mean, I think that's reasonable. Obviously, you never want to try out a new medication on the day of a very stressful event, so I think that's definitely reasonable. And then, patients who are at moderate to high risk based on non-invasive testing for CAD may benefit. I think there are other things to consider in the preoperative period before starting the beta blocker. But if the physician makes that decision, then again, they should allow enough time for a trial of therapy.
Steve, I am surprised about the statins. You have a patient with cardiac disease, undergoes non-surgical or non-cardiac surgery, and I would say, if somebody asks me about the statins, I say, well, who cares? I will use them when I have to use. I will not use them when I don't have to use. Well, they have the highest impact of anything we are talking today here in all the studies, which is telling you that the statins are not just for cholesterol. They're antithrombotic, anti-inflammatory, and they have many things. just to say what the guidelines is that if the patient is not on statins, there are a lot of controversy of starting them. But if the patient has cardiovascular risk factors or is taking statins, you should give them. And the results are very spectacular in all the studies being done. Can you make a comment about it?
Yeah, I think for me, statins are low risk, potentially high reward. So I think in general, I favor starting patients on statins perioperatively. The study that I know the data the best is the randomized trial for vascular patients undergoing vascular surgery. So for those patients, I think I would do so. And then just a word about beta blocker. I mean, I think pathophysiologically it makes sense to use beta blockers. But I think the POISE trial criticisms we know, very high dose, started immediately before surgery. But I think from a pathophysiologic point of view, it makes sense to have a beta blocker.
So Glenn, what do you have to say about the statins?
So what is incredibly interesting to me is not only do statins have one of the best risk protection in surgery, but if you look at the PCI data, actually the strongest data for pre-treating someone with anything to decrease PCI risk is against statins, and we actually have a similar class 2A recommendation. And we perseverate forever, should we preload with clopidogrel? Should we use ticagrelor or prasugrel over clopidogrel? Should we use this stent or that stent? The thing that actually impacts peri-PCI risk, similarly, more than anything else, is amazingly statins.
I think it's another example that the best drugs that we know today are those who have multi-purpose roles. Look, aspirin. If you don't want to sleep, you take aspirin. If you want to sleep, you take aspirin. You have a headache. If you have a headache, you take aspirin. If you have inflammation or temperature, you take aspirin. And look what does to the clot. Statins is the same thing. We have done a lot of work with Juan Badimon, I don't think he's here, with the statins. And I will tell you, are so powerful from anti-inflammatory and are so powerful as antithrombotics that one understands something that otherwise, if you think about cholesterol, you really don't understand it. So I think it's a very interesting point. So Roxana, you're an antiplatelet person. Let's go into antiplatelets. I'm not talking about the dual antiplatelet stuff yet after stenting. This is at the end. But by reading what these people say, in these guidelines, and that is, if the patient is not stented and take aspirin, you continue as before. Then they say, if the patient is not stented, is not taking aspirin and undergo an elective procedure, don't start aspirin. And finally, if the patient has a stenting, we will discuss this in a moment. Do you agree with all of that?
No, I do, and I think it's kind of the same as you.
Excuse me, you're a ticagrelor person, not an aspirin person.
No, it's okay. I'm thinking about.
She's both.
Yeah, well, we're trying to see if we could give ticagrelor without aspirin, so that's a separate question. But I think the very important point here is that the use of antiplatelet regimens in the perioperative period is actually, I always say, if your surgeon doesn't want to operate on aspirin or on clopidogrel, find another surgeon, because I think there are ways that we could manage these things. And in fact, there are studies being planned to give these agents in the perioperative period to enhance very much the outcomes of the patient. So I think in many, many ways, depending on the patient, you have to have, again, the team approach in figuring out what's best, the risk-benefit issue.
Thank you. Now, Tara, you are dealing with the surgeons every day. You're up there. And let me ask about anticoagulants. And again, I'm not going to quiz you. I will tell you what guidelines say, and then you give your own opinion about it. Now, let me see. If the patient is on atrial fibrillation and the surgical procedure is non-invasive, cataract and skin, and that's important, but all the others that you penetrate, vascular or intraperitoneal or chest, are higher risk. If you have this problem, so you continue anticoagulants if the ophthalmologists and the dermatologists agree with you. So that's one issue, and I don't think there's any question about it. The second one is you have a problem here. You have a mechanical valve. and your INR, and the patient needs a cholecystectomy. I can only tell you that the field is very controversial, whether you should be breaching or you should leave things for a while, for a week, and the incidence of events is very small. What is your opinion about this case? The mechanical valves.
I think it also depends on which mechanical valve we're talking about and what the
Good.
intrinsic risk of the patient is. For example, mechanical aortic valve in an otherwise low-risk patient, you can just take them off the Coumadin, let it drift down, then restart it after the surgery. If they're higher risk, have atrial fibrillation, have a history of stroke, have a history of heart failure, you might want to consider bridging with maybe a low molecular weight. The mechanical mitral valves tend to be a little bit more problematic. They're a little bit higher risk of thrombosis. Those patients I would definitely bridge. And in the higher risk patients, I might want to admit them and bridge with heparin.
Very nice. I think what you're doing, you're individualizing, but certainly the St. Jude aortic valve is really it's not very thrombogenic, but the mitral valve could be a different issue. Now, the only question here is you might decide to do breaching on patients that otherwise people feel more free to not to give anything. And actually all the data evolving in the literature, we are all aware is that using low molecular weight heparin versus not using anything, even heparin makes things worse. So these are very significant trend against breaching unless you are dealing with a patient at high risk. That's what basically is. But then there's another issue. About a few weeks ago, a fellow calls me and says, you know, a patient has an INR of 8 or 9, and I'm going to give vitamin K as crazy. I say, you are crazy. Because vitamin K take a while, the antagonists take a while to really antagonize the Coumadin. So I think that if we face a situation, I think the frozen plasma is the way to go. And then to, you know, or give the prothrombin complex. But I think we should get away because when you start giving the vitamin K, then the literature is full of problems. And it peaks when you don't want to peak. You want to peak much earlier. I think is a point I wanted to make. We know very little about the new oral anticoagulants on the business we are discussing, so I escape. Now I would like to get into the final point about the stenting in dual antiplatelet therapy. I just like to get there just because it's an issue that is within the context of what we are discussing today, and you are giving a lecture at noon. But I like to make a couple of 3 points, and I'd like you to respond, Glenn, because I think it's important. Here what we are dealing basically is with a patient who you're putting a stent, and is a high, what is the high risk for thrombosis in these patients? And what is in the literature is that if you do a PCI, it's probably a couple of weeks. If you do a bare metal stent, it's 1 month. Drug-eluting stent, you know, you can go from 6 months to 12 months. This is what is in the literature. What is very striking is the change in the guidelines by the European people last month, in which they don't care anymore about what stent you use, what device you use. They say drug-eluting stents are as good or better than bare metal stents. So they are now willing to go for a single month, if it is necessary, on a procedure if you're using a drug-eluting stent. So this is a huge change into the way we have been. But I'd like to read exactly what they wrote because I don't want to leave you with a false impression. But this is the story, basically this. The focus update has removed the previous differentiation in dual antiplatelet therapy between next generation drug-eluting stents and bare metal stents. They talk about clear superiority of the next generation dual drug-eluting stents over VMS in patients with short, 3 to 6 months, or ultra short at 1 month. Dual antiplatelet therapy duration after stent implantation could be in some cases just 1 month. No longer any justification for preferring VMS over drug-eluting stents on the grounds that using VMS would allow a shorter duration of dual antiplatelet therapy, something they believe is a major breakthrough. It's a very interesting change. What do you think, Glenn? You think they're going too far?
No. So first, I actually was involved with the European DAPT guidelines for
So,
reasons we can't discuss. I'm not an author, but I'm an additional contributor, so I was very involved in their discussions. It was actually as early as 2014 when the Europeans did their myocardial revascularization guidelines that they had concluded there was absolutely no benefit as far as stent thrombosis with bare metal stents. And even back then, they had said there is no indication for bare metal stents. So they have been years ahead of us in this. Roxana and I probably would agree that in 2016, when we did our DAP guidelines, we probably should have done things a little bit differently. And that's hopefully something that I hope we correct in the next year regarding the American view of bare metal versus DES. When you look at the time for when the minimum time before you should do surgery after stenting, you can pick and choose whatever study you want. There are studies, if you read the American and European guidelines, that say you should not do it within 4 weeks. You can also find studies that say you should not do it within 3 months. And you can also find studies such as the VA analysis that says you should not do it within 6 months. So I think there is still a gray area and people can pick and choose. The Europeans did change their absolute minimum, but nevertheless, they still encourage you to wait a longer period of time. So I still think if you synthesize American and European guidelines and all the studies, there really is a gradation. Certainly in someone where it is very time sensitive, such as cancer, perhaps 1 month might be ideal. But certainly for other semi-elective or time-urgent surgeries, perhaps 3 months, or if truly elective, then perhaps 6 months. And as with everything else during this 1-hour conference, I completely agree with your theme that rather than sticking to something because it's 2A or 2B or 1, we take the gestalt of the entire patient and individualize for that particular patient.
now, Roxana, before I go into you, let me say that the patient can continue with these drugs, but goes into an elective surgery and may bleed. So the data from Mayo just came out is interesting. They look at 29,000 people, and then 5% had the stents. And what they found is what we all know, that all the bleedings most are in the first year, but are closer and closer to the time of the intervention. Now comes the issue of how we approach the patient, and I'd like to ask for a moment, making a comment first about ticagrelor. How many times we are called, when do we stop the drug to ticagrelor, particularly when the patient undergoes some type of a procedure? And now this has moved from 5 days to 3 days. I just want to tell you, this is important because this is a question we all have constantly. But now I'm going to tell you, Roxana, what is coming out from a number of studies, and that is, let's take 3 patients. High risk for thrombosis and high risk for bleeding. This is one. Another, low risk for thrombosis and high risk for bleeding. And the other one is high risk for thrombosis and low risk of bleeding. What is fascinating to me is that you treat all of them the same way, and that is you continue to give aspirin and you discontinue the P2Y12, and then you restart 3 days after the operation, except if there's spinal surgery and you stop the aspirin too. Are you in agreement with that? I mean, this is a very general, but it's an interesting rule to keep in mind because we are all obsessed bleeding and thrombosis. It seems to me you do the same for everybody.
That's true, and only because we are talking about a very small period of time, which is the peri-procedural timing, versus a chronic evaluation of a patient where, for how long, and what you do afterwards, where bleeding and ischemia risk become even more prevalent and very important. I think it's in the peri-procedural period, you do think about what's the procedure, what's the urgency, and as Dr. Levine just mentioned, is that we worked very, very hard to kind of really go through the data and try to give some form of a guideline that fits what data is there. But at the end of the day, I think you do treat, as you said, exactly like that, and think about the type of surgery, the urgency of the surgery, and the ischemic and bleeding burden on the patient, and make those important choices. I want to go back to the 1 month issue, and I'm not so sure that we did the wrong thing about the bare metal stents, et cetera. In 2016, when we were working on that, the data that, the only data that was available for a superiority of a drug-eluting stent in a randomized prospective fashion was this drug-coated stent that's not available in the United States, which is the biomatrix stent. And drug-eluting stent work is being done right now in looking at the 1 month evaluation, even in Europe. So while maybe they're ahead of us, all of it is about collection of registries and data and propensity matched data versus a prospective randomized study where we were more strict in that, and maybe we're making a mistake about that, but I think it is important to think about that and on the context of why we did that, what we did in the
Thank you. Prashant, last question for you. You have been very involved in this field to the point that you have written the guidelines for Mount Sinai for everybody and anesthesiologists and so forth. And you wrote the guidelines for us 2 years ago and are pretty strict. Let me ask you a question. Are you going to change it? Based on all the discussion today. Remember, you did this 2 years ago.
Yeah, it has to be revised. Because in terms of the timing of elective surgery and the discontinuation of the P2Y12 receptor antagonist, it's too conservative.
Well, it's very strict, and I can tell you, I faced the surgeons so many times with just canceling some of my patients that had surgery that is very troublesome. So, and I think it's better that we move on because the whole field is becoming much more liberal and intuitive, and I think we have to take advantage of this. Otherwise, I think that we will be rather behind. Well, thank you very much. Do you have any questions? So we have 5 minutes. No question? Then I have a question for each of the speakers here. And I will start with you. Tell me, of everything what has been discussed today, is anything that is striking to you, is exciting, that maybe will make a change in the way you deal with these patients? I will ask the same question to each of you.
I think the most benefit that I can see for patients would be to get a truly kind of disciplinary approach to preoperative evaluation, because from my experience in a couple of different hospitals, the main barriers remain what the cardiologists and the medicine people think pre-op risk is, and what the anesthesiologists think the pre-op risk is, and what the surgeons think the pre-op risk is. So to me, I think getting those groups together would probably make the biggest difference.
Thank you. Tara?
I'm interested to see in what happens with the dual antiplatelet guidelines. I'm very excited to see what happens with that. Aspirin. I do agree with Steve that the most important part about all this is communication. I would also like to stress that it's not just about preoperative evaluation, it's about perioperative evaluation, and following the patients after the surgery is just as important as screening them before the surgery. I think that's when you can catch a lot of things early and treat the patient for whatever MACE they may have after the surgery.
Good. Catherine?
Yeah, I agree, of course, with the individualized approach. And I think the exciting part now is the dual antiplatelet therapy and being less conservative and, giving the patients the most benefit of those interventions.
Glenn, you are the last. I'm sorry. I have to ask Roxana. You are the last. Roxana?
Oh. So the only thing I wish for, Dr. Fuster, is that I wish we had surgeons here, these empty seats for the surgeons. Our surgeons and anesthesiologists should be here in front, not the cardiac surgeons, obviously we always have, but I'm talking about our general surgeons and those who are reluctant, because it is important for them to understand what's going on, that we need not be so aggressive in stress testing everybody That's exciting. That reduces resource utilization, and also in liberalizing the use of dual antiplatelet therapy when the burden of disease is so high. And I think I wish that they were here so they could feel more comfortable.
It's a good point. Thanks, Roxana. So, my friend, what do you think?
Um, so, I think that kind of as we continue to reframe perioperative care into what Catherine was mentioning, and this perioperative encounter, this perioperative moment, it's an opportunity to take care of the patient, really independent of whatever surgery they're having, and an opportunity to engage all of the team members, the surgeons, the anesthesiologists, the internists. It's broader than whatever surgery or procedure the patient's having.
So, Glenn, you have the last word.
Two quick comments. One is if you look at the American guidelines in particular, you will find almost no Class 1 recommendations, and specifically almost no recommendations to actually do something affirmatively, which shows the very conservative and I think appropriate nature that almost nothing has actually been shown as far as looking for ischemia to be of benefit. So in no case are we obligated to go looking for ischemia. The other related comment has to do with the whole concept of looking for ischemia. Again, we are not supposed to go looking for ischemia in general in the asymptomatic patient. We're told that multiple times in both guidelines. Yet in some cases, we're basically cornered into doing exactly that and getting a stress test. And I would pose to you, we still have absolutely no idea what to do with that stress test result. Again, if you read both guidelines, you will see statements that the finding, first, of scar has absolutely no predictive value. Yet if you read the guidelines, you'll also find a study that showed that a negative test had there was an incidence of 1%, whereas scar, there was an incidence of 7%. So the guidelines themselves are conflicted with scar, and then they're even more conflicted with ischemia. Some telling us that we only do a cath if there is 20 to 50% ischemia, which is a lot of ischemia. But the problem is, if we go looking for CAD, what do we do with it? Because again, we are told we should not revascularize the patient unless it's otherwise clinically indicated, and we have studies that show revascularizing the patient, unless they happen to have left main disease, is of absolutely no benefit. So my biggest concern is that we are boxed in to looking for ischemia or CAD, then we have absolutely no idea what to do with it.
Yeah, thank you very much. I think you are summarizing very well. The critical issue that I face with this presentation this morning is exactly that. We could present a patient and we will still be discussing the first patient. But what is important is at least we get into the concepts that are evolving. It's the only way to address an issue like this, and then you individualize. Otherwise, it would be very, very difficult to just make statements on a given patient. Glenn, I really appreciate very much you visiting us today, and you have been a pioneer in this field. I have to, again, talk about Prashant. He has written a lot about it, particularly with Kim Eagle. And to all of you, thank you very much and you for attending this.